Sudhakar Singh also.
Hello. Hello, sir.
Right.
Hello, Dr. Vamsi. Hello, Dr. Balaji and Dr.
Yes, sir.
Kanan. How are you all?
Good evening, sir. Good evening, sir. How are you?
Hey.
Yeah.
Kanan Machan, how are you?
Meeting is now streaming live on YouTube. Okay.
Yes.
So what, Paneer, shall we make a beginning or?
Balaji is going to start.
Yes.
Okay.
Yeah. Chetan, it is live now.
No, I think Netcare service is not live.
Right.
Okay.
Yeah, Chetan, shall we start? Yeah. Thank you, Chetan. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji, DSM for Alchem Aspiria Division. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on vildagliptin, titled Views on Vildagliptin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today eminent senior diabetologist Dr. A. Panneerselvam sir, who will be our moderator for today's panel discussion. Welcome, Panneerselvam sir, for today's meeting.
Thank you, Balaji.
Take this opportunity to give a short introduction about our moderator, Dr. Panneerselvam sir. Dr. Panneerselvam sir is a senior consultant diabetologist who is known to all the doctors in Tamil Nadu. Doctor has completed his MBBS from Chengalpet Medical College and MD from Stanley Medical College. Doctor was formerly assistant professor of diabetology in Kilpack Medical College. Doctor is a management trustee and chairman of Aruna Diabetes Research Foundation, Chennai. Doctor is also a co-chairman of various diabetes conferences. He is a co-chairman of Diabetes Association of India Southern Chapter, Chennai. Doctor has contributed various articles in the field of diabetes in various national and international journals. Doctor is a recipient of various awards. Doctor is a recipient of Diabetes Awareness Initiative Award in the year 2015 in Diabetes India Conference. So with this short introduction, I once again welcome Dr. Panneerselvam sir. Welcome, sir.
Thank you, Balaji.
Take this opportunity to welcome all the eminent panelists who had joined us for today's panel discussion. Let me take this opportunity to give a short introduction of all the panelists. Firstly, I'd like to welcome Dr. Vamsi Mohan sir. Vamsi Mohan sir is a senior consultant physician and diabetologist who is practicing at Chennai. Doctor has done his MBBS and MD from Madras Medical College, and also doctor has completed his fellowship in diabetes and metabolism and a diploma in acid peptic disorders, and he is a certified speaker and trained ADA and endocrine society. And doctor is currently associated with SP Hospital, Adambakam for almost 30 years. He is the head of the internal medicine at SP Hospital. Doctor is also a consultant physician and diabetologist at OrthoMed Hospital. Doctor is a principal investigator of various diabetes trial. In fact, even in EDGE trial of vildagliptin, doctor is a principal investigator. So we are fortunate to have Dr. Vamsi Mohan sir as one of the panelists today. Welcome, Vamsi sir, for today's panel discussion.
Thank you.
Take this opportunity to welcome the next panelist, Dr. N. Kannan sir. Dr. N. Kannan sir is a consultant diabetologist who is practicing at Chennai. Doctor is associated with own clinic, Chandra Diabetes Care Center, Chennai. Doctor has completed his MBBS from Stanley Medical College and postgraduate from Madras Medical College. He has also completed his postgraduate diploma in diabetology from Annamalai University. Doctor has conducted various diabetes camp in North Chennai, in rural areas, completely in Chennai, particularly in North Chennai where he is practicing. Doctor is also a participant of various diabetes investigator trials, and doctor is also participant of Legacy study, TIDE study, and he is also a part of various other clinical trials in the field of diabetes. So he is also a visiting consultant at Apollo Hospital, Tandayarpet. So we are fortunate to have Dr. Kannan sir as one of the panelists. Welcome, Kannan sir. take this opportunity to welcome the next panelist, Dr. R.B. Sudhakar Singh, sir. R.B. Sudhakar Singh, sir, is a senior consultant physician, and he is currently associated with SRM, Sri Ramachandra Medical College Hospital and at Porur, and also he is also associated with at his own center at Adayar. Doctor has completed his MBBS in the year 1994, and he has completed his post-graduation in the year 1998. He has got his primary areas of expertise is teaching and curriculum development, clinical and administration. Doctor is teaching faculty at SRMC, and he has got his own center at Adayar, Chennai. So we are fortunate to have Dr. Sudhakar Singh. Sudhakar Singh, sir, welcome, sir.
Thank you, sir.
To this panel discussion.
Thank you.
Take this opportunity to welcome the next panelist who will be joining in meantime. Dr. S.R. Ramakrishnan, sir, is the next panelist. Dr. S.R. Ramakrishnan, sir, is a senior consultant physician who has got experience of 20 years. He is a professor of medicine at SRMC Porur. He is also a principal investigator of various drug trials, including Covishield vaccine. Doctor has got credit of over 30 publications in various national journals. So with this short introduction, welcome Dr. Ramakrishnan, sir, who will be joining. So with this short introduction, let me hand over the session to our moderator, Dr. Panneerselvam, sir. Sir, you can set the context for the meeting. Over to you, sir.
Right. Thank you, Balaji. I wholeheartedly welcome all our panelists, especially Dr. Vamsi and Dr. Kannan, Dr. Sudhakar Singh, and yet to join Dr. Ramakrishnan. So today, Villagliptin, of course, we started using this molecule from 2007. At the time of introduction, so the knowledge we had only sparse because a new molecule, new mechanism of action. So far, we heard about the pancreatic beta cells stimulated by the sulfonylurea, metformin retarding the absorption of glucose or clearing the insulin resistance, and insulin metabolizing the glucose. That was the mechanism for a period of 30, 40 years or even 70 years we heard. But after the arrival of gliptin and your gliflozins, thiazolidinediones, so the mechanism of action and different pathophysiology for which these molecules are discovered, how they are clinically used. Now we have almost 13 years of experience, 13, 14 years of experience with this molecule. After the arrival of especially gliptin and gliflozins, the management of diabetes totally got changed. Otherwise, after 2007 or even from TZD and AGA onwards, otherwise from 2000 onwards for the past 2 decades, enormous changes or modifications in the management of diabetes. Unless otherwise we update our knowledge and share our experience like this, even though this molecule is in use for more than 14 years, we are going to share our experience and knowledge in this platform. So to start with, we have, I think, 6 questionnaire. And the first will be taken up by Balaji, to whom Dr. Ramakrishnan is yet to come. Shall we ask Vamsi to take over?
Yes, sir.
Verify trial only, Vamsi. It is for us, whole
Yes, yes.
Villagliptin topic is nothing new for us. So you can discuss
I think
about
we've done this a number of times.
huh?
I think we have done this a number of times.
A number of times, and I used to tell Jovial also, for teacher the subject is same, but for the students the subject is different. Students will keep on changing, but teacher will be the same. So likewise, we keep on talking about Villagliptin for so many years. So you can touch upon verified trial. So will you share a slide from there?
There are no slides, there's only a talk.
No, there is slides. Shall I start from here otherwise?
Sir, yeah, that is actually a point of discussion. So, like, sir will discuss on the topic, sir. Yeah,
Instead of discussion, I think the materials also there visible. Of course, let us discuss. We can show the information also.
yeah, sir. I'll do it from a back end, sir.
Right.
Yeah.
Yeah, sir. Yeah, sir. Meanwhile, Vamsi, sir, you can start it, sir. I'll just.
Yeah. Okay. We know diabetes is progressive, and over a period of time, glycemic levels tend to go out of control. And from Wikipedia, we have learned that treatment with monotherapy fails after initial average period of 3 years. to about 3.5 years. And overall, what we have seen from the various data analyzed is majority would require 2 or 3 drugs by the end of 5 years to keep their sugars under control. All these years, we've been like more promoting, starting with a monotherapy, intensifying the monotherapy, and then adding a second drug much later when the A1C goes out of control. And we have found that this kind of treatment does not give the legacy effect or benefit to our patients. And therefore, we have seen quite a number of increase in the mortality rates due to micro and macrovascular diseases. So it was contemplated that why don't we start and intensify the treatment right from the beginning instead of stepwise treatment as has been advised by the various state bodies and guidelines. So verified trial was one of the first trials which contemplated combined therapy with metformin vildagliptin right from day one versus metformin monotherapy, which was upgraded as the sugars were out of control. So this was a multi-center, multinational, double-blind, randomized trial. In this, patients, after initial randomization, like they were put on metformin and titrated in about 3 weeks to the maximum accepted dose between 1,000 to 2,000 milligrams. And then they were divided into 2 arms, metformin plus vildagliptin, metformin plus placebo, and were followed up. There was a period of what is called the initial failure, where the A1C was checked twice within three months. And if it was more than 7, it was considered failure. So both arms, what happened was people who were not on control in the metformin arm plus placebo arm were shifted to metformin plus vildagliptin arm. So likewise, it was found that at the end of 5 years, the results with monotherapy compared with the dual therapy was, in the treatment arm where dual therapy was used, the time for failure, treatment failure, was 62.1 months. That is nearly more than 5 years, compared to about 43.6% with metformin monotherapy, showing there's a wide gap when we use 2 drugs versus monotherapy. So again, there was a 49% risk reduction to treatment failure. If you compare it to the other way, the risk reduction was nearly 50% when 2 drugs were used compared to monotherapy. Here, the main thing was the A1C to begin with was not very high, between 7 to 7.5. So the A1C to begin with was only so much, and people benefited by using these 2 drugs, not only in treatment, reduction in treatment failure, but also having A1C control for a longer time. So from this slide, what you can say, I think most of it I've already talked about. So early combination treatment significantly reduced the probability of initial treatment failure earlier. The time to treatment failure compared to much longer. So people with dual therapy did much better compared to people who were on monotherapy and intensified monotherapy. So from this trial, what we have learned is that you need not have a high A1C like previously advocated. AD was advocating 9%. The IDF and WHO advocated around 8 to 8.5% to initiate dual therapy. But I think from this, what we have learned is it's a very safe combination with like metformin. We can get results without much of hypoglycemia. That is the main thing. So you can get these people to less than 7% without the dreaded effects of weight gain or hypoglycemia. So one of the significant trials what you had of late. Dr. Panniselvam?
Yes, very good. So it showed not only verified trials information, it poured your experience also, as you have ended like no hypoglycemia, no weight gain, because while we combine metformin with sulfonylurea, definitely. So the beta cell apoptosis, beta cell exhaustion, failure, and after 2 or 3 years, despite adding sulfonylurea and metformin, we have to add after 6 or 9 years, we have to add insulin. Despite adding insulin also, 30% of our patients are not under control. We label them as uncontrolled diabetes or non-responders up to 2000. But after the arrival of this molecule, combination with the metformin and gliptin, so gliptin persistently elevates the GLP-1. Metformin, in addition to clearing the insulin resistance, it also promotes GLP-1. This combined GLP-1 helps the so-called exhausted beta cell, failed beta cell, to secrete insulin naturally. Whenever the blood sugar goes high, it secretes insulin. Simultaneously, whenever the hyperglycemia is there, it suppresses the alpha cells also. Whenever the blood sugar goes down, alpha cells are stimulated. So that only the hyperglycemia is not there and the weight gain also not there. And the combination, as we pointed out, the prolonged period, we could be able to prolong the beta cell function. It is not getting exhausted. That is the lesson we have learned recently from verified trial. Thank you, Vamsi. We'll move on to next point. Balaji, next point you can. Next is, I think, EDGE trial. EDGE study. So, Dr. Kannan, would you like to take?
Yes, sir. So, thank you for the opportunity given to me, sir, and also welcome for this opportunity. So, EDGE trial is a unique trial, is a real-world evidence trial. Was comparing the vildagliptin on the other dysglycemic agent. Here, the concept is began the same as with our verified trial also. See, already the patient, the newly detected diabetes, almost the 50% of the pancreatic dysfunction will be seen on the macroscopic complication section. Then EDGE trial clearly allows the effectiveness and the tolerability of the vildagliptin in Indian patient with the type 2 diabetes mellitus. It is a real-world evidence study. Here, what they found, even if the patient couldn't be able to tolerate the metformin, if I give the vildagliptin as a monotherapy, that is shown a clear effectiveness regarding with the glycemic efficacy as well as the durability. But in EDGE trial, they combined they were forming two arms. One arm is the vildagliptin with the other dysglycemic agents, and the other arm is the other dysglycemic agents with other combination, dual combination. So we are able to see that in vildagliptin arm with the other dysglycemic agents and comparing with other real-world evidence of active comparator with the other active dysglycemic agents, they are able to see that as a primary efficacy endpoint regarding the reduction of HbA1c more than 0.3 without having the peripheral edema. That is very, very important because most of the diabetic patients will have the background of any heart failure. So we want to evaluate this. Vildagliptin will provoke for the heart failure. That is one primary endpoint. The secondary endpoint, as the drive of the hypoglycemic event has been evaluated with the primary endpoint. The third endpoint was the discontinuation due to any GA disturbances, because most of the metformin patients are going for combination with the vildagliptin have the format of any GA disturbances and weight gain also. So this is the primary endpoint. On the secondary endpoint, they were able to see the achieving the target less than 7 without any hypoglycemia and the weight gain. So here in EDGE study on vildagliptin and combination with the other other dysglycemic agents like sulfonylurea, metformin, glitazone, and other SGLT inhibitors, and comparing with the other dysglycemic agents, they were able to find out there was excellent reduction in the efficacy, and the durability was well maintained almost for 1 year. This is 1 year study, the real world evidence study. So the vildagliptin arm shows a clear efficacy and safety regarding with this effect on both alpha cells as well as beta cells, because it has a pronounced effect on the glucose dependent insulinotropic action. More than that, our Indian phenotypes are highly activated with the DP4 activation expression, and therefore even with once a day doses, two times a doses of vildagliptin, this Indian phenotypes have clearly shown clear glycemic efficacy and durability, and also safety wise also been proved very well by the verified trial. And already alluded by our Dr. Vamsi, in verified trial, they have seen the primary and secondary endpoint. There was another important so-called exploratory endpoint, because this verified trial is especially for the glycemic durability and the effectiveness, but it is not meant for the cardiovascular outcome trial. But they found the exploratory educated cardiovascular outcome. But they have found that they're able to see a numerical benefit in the cardiovascular outcome regarding with the verified trial. The same has been proved in EDGE trial also. So it is compatible for all the Indian subtype of patient. Even though it's international study, the Indian patients were already recruited by 11,000 patients have been included. So this is one of the Indian study, pan-India study have been recruited both internationally as well as nationally, and so the efficacy and safety regarding with the vildagliptin and comparing with the other dysglycemic agents.
Right, Dr. Is there any point, Dr. Kannan? Hello?
Sir?
Kannan, is there anything to add?
Nothing, sir. I've already.
Kannan, you have very well highlighted. So, as this sentence pointed out, how do you see vildagliptin as a worthwhile add-on treatment option to already metformin sulfonylurea is there? and metformin sulfonylurea plus insulin or metformin sulfonylurea SGLT inhibitor. So once we add vildagliptin, so as we all know, because of gliptin effect or GLP-1 effect, so the beta cell comes into action. If they are on sulfonylurea, if they are on insulin, better reduce the dose of insulin or sulfonylurea because sometimes they may face hypoglycemia. So this is another practical aspect. As he pointed out, so the lot of positive effect. For example, vildagliptin as add-on therapy to insulin improves glycemic control without increasing the hypoglycemia. Of course, this is without increasing the hypoglycemia, but many patients face hypoglycemia in clinical practice. So we should not neglect like this. Once they face low sugar symptom, better reduce the insulin dose rather than avoiding the gliptin, because earlier the cost of gliptin was high. And even including doctors were under the impression because of its cost, the molecule is so powerful. Let me stop. Today also, when gynecologist, I want to stop gliptin, it causes a frequent hypoglycemia. Already she is on glimepiride 2 milligram BD. Instead of reducing the glimepiride dose, she wants to stop vildagliptin or gliptin. Because the understanding, of course, being the other specialty, they may not be knowing, but unless otherwise we highlight to them, gliptin is safer than your glimepiride. Let us reduce the dose of glimepiride. Let us reduce the dose of insulin if they face hypoglycemia. And the combination of SGLT inhibitor and DPP-4 inhibitor also very much effective because we know the mechanism of both. So your endogenous glucose production or hepatic glucose output is enormous. Both are getting suppressed in this combination. As DPP-4 inhibit glucagon secretion and reduce endogenous glucose production or neoglucogenesis, one can speculate that combination of DPP-4 and SGLT inhibitor would prevent the increase in the endogenous glucose output. Otherwise, fasting blood sugar will get effectively controlled. SGLT inhibition and produce the additive, even synergistic effect in the A1C. Otherwise, you can combine. So that means there are a lot of companies combining gliptin with your SGLT inhibitors. And so many combinations are now available in the market. So once we combine gliptin or SGLT inhibitor with the existing sulfonylurea or insulin along with metformin, so clinical clue for our practitioners is reduce the dose of sulfonylurea, or sometimes we may have to stop sulfonylurea. And we have to reduce the dose of insulin. Sometimes we have to stop insulin also. That is the lesson we have learned from EDGE trial. So thank you, Dr. Kannan. We will move on to next topic, next agenda or next point. Now you have to come down. So next is, how do you see the vildagliptin as worthwhile add-on treatment option to metformin, sulfonylurea, metformin, insulin? No, this is, I think, same point we have discussed. We'll go to next one.
I think you already mentioned it,
Yeah.
Dr. Pandya.
You come down. Yeah. Here, in type 2 diabetic patient with reduced renal function, adequate glycemic control is essential to delay the progress of kidney dysfunction. But they are at a greater risk of experiencing hypoglycemia, especially with the long-acting sulfonylurea as well as insulin also. So how would you assess the role of vildagliptin in CKD patients? So, Dr. Sudhakar Singh.
Yes, sir. Good evening to one and all. At the outset, thanks for this opportunity. My thanks goes to the Alkem and all the panelists and my co-speakers who have set the stage to a great momentum. I think Vamsi sir and Kannan has had a very aggressive points to favor the use of vildagliptin as probably to initiate as a monotherapy or in combination therapy with very few side effect profile and with a lot of benefits to come up with adding a vildagliptin to our patients' treatment choice. My area of discussion, which has been given to me by the panelists, the moderators, the use of OHAs in kidney disease. The biggest fear for a physician or a treating doctor is whenever the patient comes with some kind of a renal compromise symptoms like pedal edema or oliguria, and when you look at the reports, when you have a urinary findings of 1 plus 2 plus albuminuria and your protein creatinine ratios going up, the patient himself is very worried that the medication list which he's been taking, whether he's safe for the kidney or not. And when you look at all the anti-diabetic medications which we have in our armamentarium, insulin probably we all know is the safest, which does not have any adverse effect with regards to renal functions or on the kidney. Liraglutide is also one of the safest drugs which can be used when people have compromised renal functions. But when we take oral hypoglycemic agents, we are in a dilemma that whether we can go at an optimum dose with the existing OHs we have. If you look at only the DPP-4 inhibitors, there are DPP-4 inhibitors which are predominantly excreted by the kidney, and there are DPP-4 inhibitors which are not at all excreted by the kidney. There are two extremes of DPP-4 inhibitors we have. On the one hand, we have sitagliptin, which has a predominant excretion through the kidney. On the other hand, we have liraglutide, linaglutide, where we have predominant, excretion is not done through the kidney at all. So we have two, extremes of DPP-4 inhibitor. But vildagliptin is a safe option here, where this does not have a predominant renal excretion. It has only a moderate renal excretion. So we can use this, as an advantage to us in adding vildagliptin for patients who we think that these patients are going into develop some kind of a renal complication. The advantage of having vildagliptin in our armamentarium is, as you start seeing that the patient's GFR started reducing, you can safely start reducing the vildagliptin dosage. You don't have to change the medication. The recommended dosage scheduling for vildagliptin in case of renal compromises, more than a GFR of more than 60 ml, we don't have to do any dosage adjustment. We can give 100 milligram per day, either once a day dosage or 50 milligram BD. But when it is between 30 to 60, probably you can cut down by half the dose. Like 50 milligram OD is more than enough to have the adequate beneficial effect. Even in less than 30, people have tried vildagliptin, and even in end-stage renal disease where people are on dialysis also, vildagliptin at the dose of 25 milligrams still has its beneficial role, in these kind of patients. One more important problem in renally compromised diabetic patients are very frequent hypoglycemias. This is a very important challenge we have because these renally compromised patients go into recurrent hypoglycemias. Vildagliptin, by its class effect of DPP-4 inhibition, plus the effect, appropriate dosage adjustments when compared to other OHAs, can minimize hypoglycemias in renally compromised patients. So in my opinion, I would probably, if at all asked to choose a DPP-4 inhibitor, I would go with the vildagliptin, which I can continue for the patient probably for a longer duration with only a dosage adjustment if at all the patient is unfortunate to develop some renal compromise.
Thank you, Dr. Sudhakar Singh. So as he pointed out, before the arrival of gliptins, we were finding extremely difficult. Of course, Vamsi also knows. So once they enter into renal impairment, the existing glibenclamide or glipizide, glibenclamide is considered as long-acting, and chlorpropamide also we are using. Then glipizide was the preferred sulfonylurea. Patient is not willing for insulin. As he pointed out, insulin is the best agent. Even the short-acting insulin will act as long-acting insulin because the insulin also should get degraded by the kidney. Similarly, if patient is not willing, we are using glipizide. After the arrival of gliptins, so of course, sitagliptin and vildagliptin, we require some dosage adjustment in the form of reducing the dose. For example, if they are on 100 milligram of sitagliptin, we are reducing the dose to even 25 milligram or even 50 milligram. For vildagliptin also, we can reduce the dose as 50 milligram or even 25 milligram. But even if you don't reduce the dose, they will not enter into hypoglycemia. That is the benefit or extraordinary capacity of the gliptins. Why they are not developing hypoglycemia? Whenever they enter into lower side of the blood sugar, the beta cells will not be stimulated by the GLP and GIP. Rather, it will stimulate alpha cells. Alpha cells will release glucagon. Glucagon will break down the glycogen and break down the fat and protein. It will not allow the individual to go into the hypoglycemic range. Whereas sulfonylurea and insulin will push the patient into severe hypoglycemic range, drowsiness, or even sometimes coma. So that only better maintain your gliptin, especially vildagliptin or linagliptin. And if the patient is already on sulfonylurea or insulin, better downwardly titrate the dose or stop the dose to prevent a severe hypoglycemia. Because in our practice, diabetes practice, I could say minimum 10 to maximum 20% of our patients are renally compromised patients. Now we have safe option for renally compromised patient, especially oral options. Of course, totally gone dialysis, transplant, the better agent is insulin only. We'll move on to next question, Balaji. Next is management of type 2 diabetes in elderly patient with complicated by high prevalence of CV risk factor, other comorbid conditions like your stroke, again renal problem, and caregivers problem also. Sometimes caregivers, the relatives are to certain extent helping. Many old patients are not in a position to get help from the children. And the caregivers, so-called the paramedical people, they also don't have proper understanding, even if you teach. So they should not develop hypoglycemia and they should be safely managed. So how do you see the role of vildagliptin in such a group of patients? Dr. Ramakrishnan joined? Not yet, right?
No, sir. No, sir.
No. So I think Vamsi, nothing, elderly type 2 diabetics. You can throw some points. You can unmute my Vamsi.
Yeah. Right. Sorry.
Yeah.
No, the older patients, especially elderly patients, 70 plus or 75 plus, there is a special class of population who have many comorbid conditions, and they require treatment with extra care to prevent side effects of the molecules which we use. And most of the elderly patients may not have recognized renal failure because they can have an early renal failure without any symptoms and can be brought out only when we do a regular check. We know that eGFR comes down as they age. Even for normal people, eGFR keeps dropping down. So it's not surprising when we see eGFR of 60, 65, or 70 in elderly people without any background disease also. That's probably the loss of nephrons that occur as they age. And therefore, the kidney function is usually mildly compromised in these patients without any symptoms or may not be detected at all. And also, this is a population that can have many background comorbid conditions, coronary artery disease or early heart failure, and they could be taking multiple other medications for such conditions. So this is a thing we need to recognize in these patients. And if they are diabetic, then how do we get them to control without producing hypoglycemia? This is extremely important to avoid hypoglycemia in this subset of population because of the fragility they have in their health. And hypoglycemia, as we know, can trigger off various sudden comorbid conditions like arrhythmia or sudden cardiac death, and they can just simply pass off into coma in the sleep without being aware of any hypoglycemic symptoms. So these people need extra care to avoid hypoglycemia, and therefore we should not be using drugs like the secretagogues, which have the potential to cause hypoglycemia in these patients. And therefore, we need drugs like the gliptins, and especially vildagliptin we have seen is a good drug. We can get down the A1C in these patients without hypoglycemia on its own. And therefore, the drug adjustment, unless there is renal compromise or there is heart failure, will not reduce the dosage of the drug, can be safely used as a monotherapy in these patients also. People who are being diagnosed, especially after 60 diabetes, they're usually safer to be used as a monotherapy, and therefore vildagliptin as a monotherapy or a combination with metformin would be very ideal in these patients to prevent complications in these patients. And what they find is despite the background comorbid conditions, when we use vildagliptin, they get as good results as we see in the younger patients as far as A1C is concerned. Therefore, it's noteworthy that these gliptins are probably one of the best drugs to use in this subset of population. Dr. Panir, any further comments as far as
Thank you, Vamsi. So as you have pointed out, so this is safe molecule. So if the patient, as I have repeatedly told, already on glimepiride, because many doctors still use glimepiride or glycoside very liberally. So once you add gliptin or glycosides or long-acting insulin analog, so patient may slip into hypoglycemia. So during such stage, better reduce the sulfonylurea. And even elderly people, as we all know, renal impairment also quite common. More than 30 or 40% of them are having renal impairment. So better downwardly titrate or avoid sulfonylurea, prefer gliptins, and easy to administer also, whether it is by his relative or caregivers, easy to administer. So we have to take some special care, and I could say the modern drugs, modern understanding about diabetes and drugs, they're all safe for elderly people as well as even type 1 diabetes also after the arrival of analogs. So we can make use of it for larger population. So this is elderly people and vildagliptin. Next one is Balaji. I think next. Yeah. How do you see vildagliptin versus other gliptin, Dr. Kannan? Vildagliptin versus other gliptin.
Thank you, sir. It's a very tough topic only, sir. But we have the authentic data regarding with the CETA with the TCOS trial, sir, and SAXA with Savertimi and Lena. We have two premium cardiovascular outcome trial like Carmelina and Carolina. But with Vilda, in verified trials, they have clearly found that with the primary and secondary endpoint, they have shown the efficacy and durability. But regarding with the exploratory endpoint on the cardiovascular outcome, they have shown the numerical benefit, even though it is not so significant statistically, but they have shown the numerical benefit. There are certain good cardiovascular outcome benefit regarding with the vildagliptin also. And more than that, our Indian context will respond very well with the vildagliptin once a day or 2 times a day. And more than that, most of the vildagliptin subjective patients, it has the unique property of action both on beta cells as well as alpha cells. It is regulates both insulin appropriate action regarding with the glucose dependent insulin action, and also in compensative phenomena. If the patient go for hypoglycemia, it will compensate the glucagon. That is the main concept behind the vildagliptin theory behind the type 2 diabetes management. So in the prevention of cardiovascular disease, it clearly alluded that all the gliptin showed the non-inferiority regarding with the CV outcomes, but except SAXA shows the highest signal for the cardiac failure. So with this concept, vildagliptin can be safely given for the cardiovascular patient, but should be ruled out for any classes of heart failure, even with the stage 1 or stage 2 heart failure. The arm should be taken, because all the gliptins have the impact on the heart failure. Any gliptin CETA, and then Vilda. See, in Carmelina and the linagliptin doesn't show any heart failure problem, but the same linagliptin in Carolina had the impact of heart failure by 1.21 hazard ratio. So in Carolina trial, linagliptin showed the heart failure signal around 1.2 for 2. One of the Jamba 1 molecule, linagliptin also the same impact. So the vildagliptin also, if the patient having heart failure, means the dosage can be reduced at least to 25 milligram 2 times a day or 50 milligram OD according to the patient need, or you can avoid the patient in extreme cases. In NYHA class 3, you can avoid the vildagliptin of any gliptins, but regarding with the MI or regarding with the all-cause mortality, regarding prevention of MACE outcome, this vildagliptin can be safely given among the diabetes with the pre-existing cardiovascular diseases. Thank you very much, sir.
Thank you, Kannan. We have very well highlighted. Even though all our gliptins, mechanism of action is almost for all gliptins are same, but there are some subtle differences, as he pointed out. Saxagliptin has showed more of cardiac failure, and linagliptin also to certain extent. Sitagliptin is neutral or non-inferior. Vildagliptin also non-inferior. And if there is gross failure, better downwardly titrate the dose, but it will not worsen the failure like your pioglitazone. it will not worsen the failure. So you can safely give much lower dose except saxagliptin. Along with your SGLT inhibitor, even if there is mild failure, more beneficial only. So otherwise, all gliptins are by mechanism of action wise same. Right. We will move on to next point. How do you see vildagliptin patent, the generic variant? Of course, once the patency goes off, how would you view the expanded role of economical and evidence-based vildagliptin in the spectrum of type 2 diabetic patient management? Dr. Sudhakar Singh.
I mean, I don't know how far I'll be able to throw evidence on this topic, but
we can show you just a broad view about it, because
Yeah.
we can throw our broad view as a clinician.
when the DPP-4, the OHs were introduced in the market, and when we are free to use DPP-4, we started using with great reservations of, as you all know, the cost being a limiting factor. But one important milestone that happened was the introduction of tenligliptin. So once this tenligliptin came in as, 4 months alternative of DPP-4 inhibitor, everybody, including myself, probably most of my preference were tenligliptin at that point of time, for the single reason that it was highly cost effective. Plus, we had the satisfaction that we were giving a DPP-4 inhibitor for most of our patients. And we didn't want to deny the benefit of DPP-4 inhibitors just because of cost. That is the only reason we started using tenligliptin. But honestly speaking, post this, relaxation of this price or the price control we have come, and our entire focus have changed again back from tenligliptin to vildagliptin. If at all, one molecule which has suffered a lot after removal of this patencies, it is no other drug apart from the tenligliptin. I can vouch and tell you, even in my practice, most of my patients who are already on tenligliptin, because for the want of giving other DPP-4 inhibitors, have now come back to renowned and well-established and time-tested products like vildagliptin back to these kind of patients. So we have the confidence now of giving a DPP-4 inhibitor which is time-tested and which is available throughout the world with a lot of safety concerns which have been removed with the vildagliptin. And with the price advantage, I think more and more people can probably use this as a first line of drug along with metformin, or even people who do not tolerate metformin can straight away start with vildagliptin as a first line of drug. Thank you.
Thank you, Dr. Sudhakar. As you have pointed out, once the patency had gone, the price had come down. We have broadened the usage of. Earlier, we have a hesitancy whether this patient is affordable. Even though the gliptin is indicated for that particular patient, we think about the affordability. So that was the drawback we had, even though gliptin was proved to be a good molecule. Now, that hesitancy is not at all there, because all gliptins, for example, vildagliptin, even tenligliptin, so the patency had come down and the cost is around 10 rupees. So 10 rupees per day or 2 times 2 doses, nothing for many of our patients. Here also the cost of treatment has dropped from 16,500 per month to hardly 1/3 of it, 1/4 of it, 4,400. So the cost is very much reduced. So many patients are getting benefit out of it. So that is the beauty of patency. And we have broadened the usage of gliptin, and many patients are getting controlled without hyperglycemia, without weight gain. That is the benefit all our Indian patients are enjoying now. Next topic, next come. I think, how do you see vildagliptin versus other gliptin? No, come down. You are going up. So how do you see vildagliptin versus other gliptin also? You have to come down, pull down now. That is over, I think. So what I will do now, Balaji, do I have any share screening option?
Yes, sir. Yes, I stopped sharing, sir. You can share it.
Right. So I will show a few case records of mine, how the gliptins are giving benefit for our patients. this particular patient, Usha, 2006, she developed diabetes. I saw only in 2009. 3 years she had treatment. 224 fasting, 297, A1C was 10.9. And she was on metformin, glimepiride. Glimepiride 2 milligram, one in the morning, one in the night. So she was totally taking 4 milligram. A1C came down to 7.9, but gross glycemic variability, 156, 230, 129, 269, gross glycemic variability. With this background, she came on January 2009. Now, January 2021 had gone, almost 12 years. I had reduced the dose of sulfonylurea, glyphosate G2, and added voglibose. After adding voglibose, because in this topic, voglibose, they have not at all brought. See, voglibose in India, we are enormously using. After adding voglibose, January 2009, March 2009, 92, 138, I further reduced the glimepiride dose as metformin plus glimepiride 1 milligram, voglibose getting continued. Then 139, September 2009, 6.9. Now September 2029 and September 2021, we are going to enter almost more than 10 years, no sulfonylurea. Vildagliptin, metformin, voglibose, 115, 6.5, vildagliptin, metformin, voglibose, 149, 150, 7.3, slightly going high. Then again coming back to vildagliptin, metformin, voglibose. Now after adding pioglitazone, A1C 6.8. So voglibose, in addition to blocking the absorption of glucose, this undigested disaccharide also stimulates the L cells, increases the GLP-1. Metformin promotes the synthesis of GLP-1. Already vildagliptin straight away increases GLP-1 by blocking the DPP-4. Pioglitazone clears the insulin resistance. Without further sulfonylurea, without insulin, beautifully the blood sugar is getting controlled after dinner, after lunch, breakfast, etc. So this patient is followed 6.7, 7.1 because not on diet. Then again, even 52, 101, 6.5 up to 2000. 2021 also she came 6.2 A1C. So the message is sulfonylurea 4 milligram of glimepiride stopped. So likewise, we stop insulin also for many of our gliptin users in long time usage. Metformin, voglibose, vildagliptin. So no hypoglycemia, no insulin from the beginning. 2007, the A1C was 10.9. Now 2017, 2021, A1C is persistently maintained at less than 7 or 6.5. Otherwise, this was unimaginable. Dr. Vamsi also knows. Up to 2000, 2003, with these three molecules, metformin, sulfonylurea, insulin, we found extremely difficult to pull down the A1C to closer to 7. Even if you pull down the A1C to closer to 7, frequently they develop hypoglycemia, even if you are a diabetologist or endocrinologist or cardiologist. If you delay the food, such problems will occur. So such problems are not occurring in this case. So another, this is a drug naive patient. One chronic patient also I will show. This patient had premixed insulin 35 units BD. We stopped. 89, she developed diabetes. Year of birth 1934. Now her age is almost 85 now. While she was coming to me, she was on 35 units of insulin 2 times. With this background, A1C 12 in January 2009. Again, 12 years over. After adding voglibose and metformin, 233, 138, and 191, 95, 96 within 1 year, A1C 5.9, we stopped insulin. So now we stopped insulin 11 years before, without insulin, 145, 7, vildagliptin, metformin, voglibose, 152, 136, vildagliptin, metformin, voglibose, 107, vildagliptin, metformin, voglibose. Because the Western literature, they don't talk about voglibose. But voglibose is doing wonders in our practice. So after adding voglibose with the gliptin and metformin, so the beta cells are put into normalization. So 6.2, 6.5, 6.4, 6.2, 2018, 2019, 2021, because of COVID, she started taking a lot of fruits. she wants to improve immunity to fight against COVID. But A1C went to 7.4. So it was 12 A1C in 2009. Even though her age is year of birth 34, we were able to maintain A1C persistently less than 7. Because of COVID, lot of fruits slightly went high. Otherwise, we are maintaining A1C always less than 6.5. So insulin requiring type 2 diabetes become insulin independent. Otherwise, we are in the position to stop insulin. We are in the position to stop sulfonylurea after the arrival of gliptin and the SGLT inhibitor. Otherwise, we will be able to safely control diabetes even though her age is more than 80. ACP says we have to maintain A1C 8 after the age of 60. Now, without hypoglycemia, we will be able to maintain A1C at less than 6.5 also. So with this, we will end this talk. So thank you for all the panelists. Thank you for welcome, and especially Balaji for creating this platform and discuss on gliptins. And 2 of my case records, one long-standing case and one is drug-maybe patient. So anything further to discuss also, we can discuss for some time. I think no other participant, isn't so, Balaji? Only we,
Yeah.
4 of us.
Yes, sir. Yes, sir.
Right. Anything to add, Sudhakar, Dr. Kannan?
Nothing, sir. I think we have had a wonderful discussion on vildagliptin.
Right.
We also showed that the safety part of it, that is very important. And it's effective. It's among the gliptins, it's the most powerful one as far as A1C reduction is concerned. In fact, the meta-analysis of A1C around 9%, vildagliptin brought it down by around 1.4 compared to around 1.3 for Saxa and 1.2 for sitagliptin.
We maintained also. So
yeah,
all the
so the
studies.
duration also we can maintain apart from reduction in A1C.
So durability in our clinical practice also there. Even for old cases as well as new cases.
Yes. So
Otherwise, the so-called progressive nature of beta cell, or otherwise the so-called exhausted beta cells, so they are all given real life now because of this mechanism.
yes. Right. So there.
I think so. My wholehearted thanks to all the panelists, Dr. Vamsi, Dr. Kannan, and Dr. Sudhakar Singh, and especially Balaji for coordinating all of us, and Alcom ultimately. Thank you, Balaji, and thank you all of you. So over to Balaji.
Thank you, sir. Thank you.
Sir, thank you, sir.
Always
Thank you.
You might come across in your chamber also. So I see him for more than 2 decades, always smiling face. It's a God's gift.
My pleasure, sir. My pleasure to propose again a vote of thanks for today's meeting. Sir, take this opportunity first to thank you, sir, for accepting our invitation and moderating the panel discussion today. So you have covered up the entire topic of discussion, which is planned. So thanks for this meeting, sir. I'd like to thank all the eminent panelists, Dr. Vamsi sir, Kannan sir, Sudhakar sir, for sharing your clinical perspective on vildagliptin. And I'm sure like all the points which has been discussed today will be more helpful for all the delegates who participated in today's meeting. Sir, at this juncture, we like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. Sir, we at Alcom will be continuing to serve doctors and patients by making our products available, especially our Gluvilda, Jupiros, and Volcom. So Gluvilda, just want to highlight just one point before ending, sir. Gluvilda, we had come up with the Gluvilda once daily formulation. We are one of the earliest company to bring it to the market in the month of March itself. Our own manufacturing, we had compared a 3 months trial with the parent company BD dosage on DPP4 inhibition. DPP4 inhibition of Gluvilda OD, it is almost similar compared with parent company BD dosage, which clearly shows the efficacy of Gluvilda OD will be similar to parent company. It is also, we have done also bioequivalence study, wherein Gluvilda OD is bioequivalent to innovator brand, sir. So with this note, sir, I once again thank moderator Paneerselvam sir and all the panelists for giving us an opportunity. Thank you, sir, and good night, sir.
Thank you.
Good night to all.
Thank you. Thank you all.
Thank you. Thank you. It was a wonderful learning session for me also. Thank you. Thanks a lot, sir.
All the best. Sir, you are in medicine department or endocrine department?
Medicine, sir. General medicine, sir.
Very good. Which unit?
I am heading the 6th unit.
Oh, very good. Very good.
Saturday is my admission.
பரவாயில்ல 94ல MBBS முடிச்சிருக்காரு. Heading the unit, very happy.
94 immediately I joined PG, so I finished my PG in 99 itself.
So where did
2000.
you finish your PG?
In Ramchandra, sir.
Oh,
I did my both UG PG in Ramchandra only.
And working as unit
Yeah.
chief also. Very happy.
Yeah.
So my best wishes, all the best.
Thank you, sir. Thank you so much, sir.
Good night,
Thank you all. Bye, Kannan. Bye, Vamsi, sir.